of course, it's no surprise that the first talk is the science of connection, because at the end of the day, it's all about love. It's my honor to do Dr. Lee Lipsenthal's talk this morning. Hopefully, I'll make it through it. I didn't know this, but Lee told me that the model of healthcare that we practice is called the Cartesian Model of healthcare. Has anyone else ever heard this before? Am I just the only one? Okay, so a lot of smart people out there. I guess I'm just the only one who never heard of it. Of course, this is the model we learned in medical school, the model that works really, really well for acute, life-threatening emergencies. And as you'll see in a few minutes, everyone has to agree it's based on a disease care system. And it's certainly not effective for treating or preventing the chronic diseases that we see many of us every day in our practice. Next slide. I have no control, Charles. You're in control. It all began, I think, in 1910 when Abraham Flexner was commissioned to come up with a paper that said what should go into medical schools, how should we accredit medical schools, so on and so forth. What do we do with medical education in the United States and Canada? And this report was actually commissioned for the Carnegie Foundation for the Advancement of Teaching. And right there we hit, for the first time in 1910, a reductionist approach to health. Because what made it into that paper and what didn't make it into that paper were totally separated forever until things are starting to come back now through holistic integrative medicine. So things like homeopathy were really battered. Chiropractic survived by their hanging on by their nails. So it was truly a start of a reductionist approach, limiting what we do and when we do it. Next slide, Charles. Then we had the Great Depression. And the Depression led to one good thing, perhaps, which was let's get all Americans covered in their old age so they don't have to worry about, in their golden years, being sick or not having health care. And that led to, ultimately, to Medicare. But the problem with that is Medicare led to, we'll pay for this, and we won't pay for that. So again, we hit this reductionist approach saying, well, we'll pay for your surgery, we'll pay for some drugs, we'll pay for physical therapy, but we're not going to pay for your exercise, your nutrition, your acupuncture, your homeopathy, and so on. So we ended up with this very big, what they call the war against disease. And money started to pour in. You know, after the advent of penicillin, money started to pour in for scientific research. And again, that's not a bad thing. Medical education was really focusing on the basic sciences because at the time, everyone believed that you can cure one thing with a magic bullet. They didn't realize that this is about microbiology and microbes. It's not necessarily about complex human beings, but that led to this big focus on the basic sciences, the founding of penicillin, the magic bullet mentality toward illness. We're going to fix everything with one thing. And this was a real big hit for holism. It was a huge hit because we went on this path of let's keep identifying disorders and drugs, disorders and drugs. So at the end of the day, we ended up with insurance companies. And for those of you who were in our pre-con yesterday, you heard a lot about the evils of insurance companies. But we ended up with third-party payers, huge growth of hospitals, rapid increase in research, which was okay, and a lot of money being spent on health care. But the one thing we weren't seeing along the way was necessarily improved outcomes. When it started to become too expensive, the concept of managed care came in. You know, if there's anything that's going to battle the concept of treating the whole person, it's probably managed care, which came in to say, let's slim it down, leading again to further reduction in services. So for 100 years, if we look at the history of medicine, we ended up with the elimination of therapies and treatments. We ended up with a reduction of services offered and paid for. We ended up devaluing time with the practitioner. I mean, you know, now they say you can code for your extra 15 minutes of time. We ended up putting high tech and pharmaceuticals on a platform, and we started to just label things. It had to have an ICD-9 code to be billed, and therefore we would get paid for it, and that's sort of the model that has happened. Now, I would be, some of you know this, but I trained as an interventional cardiologist. I used to put 700 stents in a year. So obviously, I'm not one to bash Western medicine. This is where we're great. I mean, truthfully, if you have a heart attack, a stroke, you need a diagnostic or a surgical procedure, that's maybe not the time that you want to start aromatherapy. I mean, you might for relaxation, but you certainly want to do it in a trauma center, right? I mean, this is where we're good. So this is what happened to us over time. Now, all of you know this. We would train, what's our first question? What is your chief complaint? Right away, that implies you're coming to me sick. You're broken. Something's not right. Well, the good news about the way we were trained in the acute care model, it gets us right to the diagnosis and treatment. We go chief complaint, history, diagnosis, and treatment. Somebody comes in with chest pain, want to make the diagnosis of heart attack, want to get the aspirin, nitro, stent, angioplasty, and everything in place. That's how we were trained to practice. So we arrive at the diagnosis very quickly. It begins in the acute setting, leads to rapid treatment. These are all the good things. We lock down the issue, come up with a plan, and away we go. So that's good for acute care. You can't breathe, we probably want to do that. But the problem becomes when we take this model and we apply it to prevention, certainly doesn't work there, and we try to apply it for chronic long-term health issues. So we end up with it looking like this. Somebody comes in, they say, I'm depressed or I'm feeling blue. We make the diagnosis. They're depressed. I know what to do. I'm going to give a FACC, I'm going to give Prozac, I'm going to give something. We make the diagnosis, we have an ICD-9 code, and we think we're ready to go. We get paid for the diagnosis, but I will tell you this, the biggest learning curve I had when I was sitting where you were sitting in the year 2000 was when I took my first ABIHM board exam, is I had to make this transition from the ill to the pill, the quick jump, depression, Prozac, high cholesterol, Lipitor, high blood pressure, ACE inhibitor. I had to make this transition to asking the question, why? Why is someone depressed? Just because you name it does not mean you know how to treat it. Is it depression because they're sitting in the dark all day? Is it because they have vitamin D deficiency? Is it because their dog just died? Is it situational? You don't treat people who need light therapy with Prozac, right? So getting to the underlying cause, asking why someone's diabetic, why someone's hypertensive, this does not come out of our Western allopathic model. We truncate the story. Chief complaint, history of present illness, diagnosis and treatment. What about the human being that's sitting there? What about this person's family history? What about what they're eating? What about the supplements that they're taking? Where are they at emotionally, mentally, spiritually? My fellows do something like this. This is their presentation. 65-year-old man, the echo shows. The echo shows? What happened to the whole person in between? The 65 and the echo machine. It's gone. And one of my fears I'm not against technology, but if we start approaching people like that, we're missing the big picture. So we make a diagnosis by the organ system. Little attention is paid to the story beyond the chief complaint and the history of present illness. The patient's whole story is not understood. And each issue becomes a diagnosis, a billable diagnosis in isolation from all the others. You guys know what I'm talking about, right? You have reflux, you have depression, you have diabetes, you have hypertension. And by the way, none of these just happen to be connected. That's a problem. So it looks like this. We have the ill to the pill. Here it is. You have irritable bowel syndrome, you get hycosamine. You have arthritis, you get an NSAID. You have a migraine, you get a triptan. You have high cholesterol, you get a statin. You have reflux, you get an H2 blocker. You're depressed, you get an SSRI. This is where we're at. And what's really striking is we spent $308 billion last year on what? Pharmaceutical therapies. The United States, North America, consumes about 50% of all the pharmaceuticals made for the entire world. And we just learned, what did we just learn, Scott? $14.6 billion on antipsychotics, $10 billion on antidepressants, $13 billion on statins, and $10 billion on PPIs, proton pump inhibitors, which, by the way, we're giving to infants and children. And I have a problem with that. So think about it. The United States of America is psychotic, depressed, has high cholesterol, and heartburn. Now, some people are looking at me, they're giving me a hard time energetically, but this is where it's at. So this is my list that I thought about a number of years ago. I said, conventional medicine, holistic integrative medicine, how did they really differ? For me, personally, as a cardiologist, well, I was taught to be reactive. You're having a heart attack, get your stent, your nitro, your Effient, everything you need. I was not at all taught to prevent heart disease, the concept of being proactive. I was born in a disease-driven model, not a prevention model. I was taught to treat the heart. People are shocked when I'm asking them about their life, who they live with, what they eat. They say, aren't you the heart doctor? I say, yeah, but it's all connected. So treating the whole person was not something I was really taught to do. I was taught to treat symptoms. Again, if you have high blood pressure, here's your pill for high blood pressure. I wasn't taught to get to the underlying cause. These are the shifts I made over the last 10 years. Now somebody comes to me with high blood pressure, the first thing, two things I'm thinking. How much Campbell's soup are they eating? How stressed are they? Where's the salt coming from? Are they exercising? Are they overweight, right? What's the underlying cause of the problem? And how do we motivate people by feeling good? Fear is not a motivator. We're all going to die. It is not a motivator. Feeling good is a motivator, no doubt about it. And one of the areas that really took a big hit during managed care medicine is the concept of spirituality being connected to health. I remember when I arrived at Scripps, I was told they just fired, or they no longer were going to have chaplains. And they also got rid of the psychiatrists too, because I guess they kept it at the same elk, because they decided they didn't make money. So all they wanted to do was take the physical body and cut out the spiritual and so on. Also, one of the things I've learned to really focus on is quality of life. I can keep people alive in the ICU on tubes and catheters forever. But quality of life is what I've learned from my patients, is what they really want. So this is going to be a different week from you guys. When's the last time you went to a medical conference and people sang, all you need is love? So in case you haven't noticed, this is going to be a different kind of week, because all of the board and the people who practice integrative holistic medicine recognize that we have to care for the whole person, body, mind, and spirit. We recognize that the emotional, mental, and spiritual aspects of healing cannot be separated from the physical. It's not possible. One of our key focuses is on prevention. How do we keep people healthy in the first place? So as an integrative holistic practitioner, we hope that you will consider focusing on health, prevention of illness, and raising awareness of disease in our lives, rather than just merely managing the symptom. And how do we do it? We do it by looking at contributing factors that are leading to illness. How do we modify them? How do we enhance someone's life to optimize their future well-being? How do we get people to be whole, or as whole as they're ready to be? So this is the way I put it to my patients. I tell my patients, if you have a sick tree, if your tree is sick, what are you going to do with it? And they say, more water, better soil, all sorts of things. Put it in the sun, give it plant food. Well, then why in medicine do we label our branches things like heart disease and diabetes, and then we go up and we bypass the branches and we cut them off or we drug them, right? So this is the way I teach it to my patients now. I say, if you want to have healthy fruit, you need to think about micro and macro nutrition, physical activity, sleep, getting toxins out of your life. You need to look at where you are emotionally, mentally, spiritually, how you're connected to community, how you're connected to the planet, what is your purpose in life. These are all the things that interact with your genes. Imagine this is your DNA that lead to either sick or healthy fruit. So the leap you make this week is you go from treating up here to looking down here, because every lecture you will hear this week will be focusing on these various aspects of health and healing. One of our goals in holistic integrative medicine is optimal health. This is what we want to have for our patients. And I like this pyramid as well as a little bit of a diagram because it reminds us what is really important for optimal health. It's not drugs and surgery. We need them when we need them. But at the end of the day, we're humans. We need clean air, we need clean water, proper nutrition, love, touch, spirituality, and so on. So we need to think about it a little bit differently. When I think about the research, and you're going to hear this research all week, you're going to hear how important it is to deal with the emotional and mental aspects of health, because there's a lot of research that tells us that anger makes you sick. 70 to 90% of visits to healthcare providers are from stress-related disorders. Yes, 70 to 90%. Being socially connected. You know what Satyananda said, the I in illness is isolation. The we in wellness is we, right? Are we physically active? Where are we at spiritually? What the research shows is that people who have a connection to a higher power have much less issues with cortisol, higher levels of DHEA, and have healthier behavior patterns. So all of these things are important in healing. This is something I learned on my journey. All life experiences, including birth, joy, suffering, and the dying process, are learning opportunities for patients and health practitioners. I wasn't taught that in medical school. I was taught to run away from the dying process as fast as I could. I never was comfortable with it. My goal was to keep people alive. That's what I do. And the reality is, healing is different from curing. And I've had to learn that all of these events, major life events in my life, in my patients' lives, are all part of our opportunity